Okay, I think we can get started. Hi, I'm Bob Nachbar. I'm in the Wolfram Solutions Department, the consulting department of Wolfram Research, and I've been doing some epidemiology modeling for the COVID pandemic. I had a couple of community posts earlier this spring, and we had some Twitch sessions where we talked about our various efforts. And what I wanted to talk about today was the extension of some of those earlier models that I had worked on. Um, and so here's the abstract, but what I want to point out though is a little bit of a spoiler. Um, while we did do some modeling with stratified models over networks and some stochastic modeling as well, a lot more needs to be done to really understand what they can contribute to modeling a pandemic, an epidemic outbreak, and so on. Also, when we had to write our abstracts for the conference, which was several months ago, other developments have intervened, and I've learned some new things about modeling these sorts of systems. And so I've adapted my work in response to those that new information. And so I'll be, including some of that in the presentation as well. So the talk is really more about methodology than applications because basically I'm a tool builder. I'm more of a craftsman than an artist, you might say. And so we'll get through this, and I hope you learn something from my talk, and I can stay on as long as necessary afterwards for questions, and we can always follow up later. Okay, so these are the things I'm going to cover, a little bit of background and rationale for why I needed to change the models I was working on earlier. A little bit of background on compartmental models. There have been several talks already, at least two today, on this topic. People have talked about non-pharmaceutical interventions. Thomas most recently with his government switch function, as it were. Um, I'll describe briefly a more realistic compartmental model that I've developed to better describe what's actually happening in the COVID epidemic. I'll talk about network models, network topologies, and then how we distribute the epidemiology model over a network, and then an example of doing that for Italy and the data for Italy. Okay. So just quickly, yes, we want to initialize everything. We can load the data for Italy from the Wolfram data repository. And here we are, it comes out as time series, and we can plot the data. And this is the typical sort of curve we see of those data, the number of confirmed cases over time, the number of deaths over time, and the number of recovered people over time. We see that the pandemic in European countries and in North America began in March. In China, that was beginning earlier in January and February. We often want to convert these raw numbers into something that is more epidemiologically related or disease related, such as the prevalence, which is roughly the confirmed cases less the number of people that have died and the number of people that have recovered. And that's this curve here. And then we've got the incidence, which is just the daily difference of the confirmed cases. Which is kind of like the derivative of the prevalence, and then the number of dead people. So we had done earlier work, we were looking at the data from China, and here we can see that the outbreak occurred much earlier. At the time when I was doing that work, late February, early March, these were all the data that we had. And I was trying to model the data for the province of Hubei, which has 58 million people. And I was having a very difficult time doing that. And somebody suggested that, well, they were able to fit the data by reducing the effective population size. And I tried that, and by reducing it to 500,000 or 100,000 or 50,000, I got fits that were better, but still not good. The recovered curves were generally in the right position, but not the right slopes. The number of people that were infected at the time, the prevalence, I could get it to go roughly through the data, but I couldn't get it to turn over properly. And I was really not happy with it. They're really unrealistic. And if you look at the parameter values that come out from this curve fitting exercise, they're really not appropriate from an epidemiological point of view. The R naughts are way too high. They shouldn't really be above 10. The infectious period is lasting way too long, 4 months, 2 months, and people just not dying at all, in this case here, are just completely unrealistic. So we wanted to try some changes, and some of the things that I had looked at was looking at stochastic modeling and some preliminary work I had gotten done on network modeling, and that seemed like it might be useful. So let me just quickly make a very simple SEIR-D model. Let me load the package for that. This is available on the cloud. There's a link at the end of the presentation to that. And the way I define the models is I just write a set of transitions: susceptible to exposed, exposed to infected, infected to recovered, and infected to those that die. And we can make a graph of that here showing the same steps. And we have a function called dynamic transmission model that basically takes the set of transitions and then returns a number of data elements that include, among other things, the differential equations and the force of infection. The force of infection comes in the model here. It's the contact rate times the force of infection, and the force of infection is essentially the number of infected people. In this model here, we're using standard incidence, so we divide that by the total population size, and we also reduce it by the number of people that have died, because they're really removed, and they shouldn't be included in the computations after they die. We define the initial conditions here. We start out with everybody being susceptible except for the number of people that are infected, and a small number of infected people, I naught. Okay, we can then define these terms, or the outcomes, the prevalence, the incidence. We have a function called incidence that takes the data from the model. We tell it which compartments are infectious, so we can, or that are sick, I should say, and it gives us the appropriate term for the rate at which they appear, and then the mortality, which are the people that die. Okay, we need to parameterize the model, and what we want to do is do that in terms of R naught instead of the contact rate. What's nice about using R naught is that we have a threshold for it, where we know if it's above 1, the epidemic's going to persist, and if it's less than 1, it will be less than that. We use the next generation matrix method to compute R naught, and for this model here, it has this expression. Very much similar to what Thomas was showing. It is the recovery rate. Well, R naught is essentially the contact rate divided by the recovery rate, but we've got some modifications to it due to deaths in the model, and that we've got a reduced incidence because of the deaths. And we define some parameters that we'll need, and we convert them all to numeric for simulation. And screen's not showing me everything that it's supposed to, so I hope I don't miss something. We need to know when the infection first occurred in Italy, and Wikipedia reported that January 31st, there were 2 Chinese tourists that tested positive, so we can set that for our first infection date. and the time horizon will extend up through today. And if we look at the results, these are the data that were actually observed. And if we use the full population size in the model, it's predicting that we're going to see the big, uh, the infection is going to really take off in July. And it's going to essentially hit most of the population of Italy. And this clearly did not happen. And if we then allow the population size to change, and if we slowly decrease this, we can see that the infection moves earlier in time, but it still isn't matching the data. It's still not high enough. And by the time we get it occurring in March, it's way too small. And now I've got the effective population down to 10,000, which is just totally unrealistic. And at this point, I decided to move on and start looking at other types of modeling for the pandemic instead of trying to play around with this particular one and try to, add band-aids to it, as it were. Okay, so one thing that we recently discovered is very important are these non-pharmaceutical interventions, social distancing, masks, government policies that cancel large social events, and things like that, closing borders, restricting travel, and those sorts of things. And they all effectively reduce the contact rate. And since the contact rate is proportional to the to R naught, the basic reproduction number, we can think about modulating R naught instead of modulating the contact rate itself, because this has a target, as I had said, of 1. Above 1, the outbreak will persist, and below 1, it will dissipate, which is the goal. Okay, so in Italy, or actually I should say in Wuhan, they closed everything down in January, on January 23rd. And the first infection, they estimated, occurred sometime around the 20th of December. So we can calculate when that occurs, and we can use a very simple function here that up until January 23rd, we've got the full force of the infection occurring, and then it dissipates as people start social distancing, as people start getting quarantined when they were sick, and so on. And so, yeah, okay, so when we use this model we incorporate this type of function into the model and use it on the Wuhan data, I can get a better fit to the data using the full population size. R naught is still very high. The death rate is still way too low. The infectious period is still way too long. So it's really just doing curve fitting at this point and not really explaining the disease very much. So let's move on from there. I wanted to build a more realistic model than just a simple SEIRD, because many other things were going on as far as people, their health states and how they were being treated and things like that. The CDC has a website that has a fairly detailed description of the timeline of events that occur. So basically, people get exposed. About 6 days later, symptoms show up. They're often tested by about the 9th day after their initial infection. If they get hospitalized, it occurs at different rates depending on age. Older people tend to get hospitalized sooner than younger people, but the average time is about 11 days after exposure or first infection. They get released from the hospital from a non-ICU setting at about 15 or 16 days after infection. If they end up in the ICU, they get released after about 3 weeks from infection. Again, very dependent on age, and death occurs at about 3 weeks, and very dependent on age. So I had a model that included 3 different infections compartments: asymptomatic, mild, and severe. 2 compartments to model hospitalized people. Essentially, they were quarantined if they're in the hospital, not able to infect other people, but still being infected themselves. And I included 3 different recovered compartments, one for the asymptomatic, one for mild, and one for severe, and of course a death compartment as well. These are the transitions, so we'll define those. We can make the model graph, which looks like this. These are the quarantine compartments here that are hospitalized, and the severely infected people that become hospitalized are in the IC unit, and they're the ones that generally were able to succumb to the disease and die. Also, people that were severely infected but not hospitalized could also die in this model. There are lots of variations on this model. This is not the only one. It's more than likely not perfect, but it will do for our purposes today. So we can define all the components of the model, the differential equations and the force of infection. And we set up the parameters. We can calculate R naught and get a relationship for beta from that. And we can define our parameters. Notice here that I'm defining essentially times for things to happen: incubation time, time to go to the to get to the hospital, time to recover, time to be released from the hospital, released from ICU, and time to die. And from those, I can then calculate the rate constants. It makes it a little bit easier to work with the data we actually have in hand. And then we can do a simulation. First, we compute the initial conditions as we did before. Everybody's healthy except for a few sick people here. And the first infection date was reported to be January 31st, so we set that. And the time horizon, we can do a differential equation solution and then compute the outcomes. And we can then see how the model compares against the data. This is the model here, and with a simple NPI function that basically has people social distancing and restriction here, and then a relaxation of that, and they start to go up again. And looking at it against the data, we can see that it does fairly well. I had optimized a few of the parameters outside of the notebook here, but R naught, the optimized value, was still way too high. And the time that it takes to die is very much on the high end. It would be better if it were closer to the median. So there's still more work to do here. Okay, so I want to use this type of model on a network and see if spreading the people out, as it were, in different communities has a benefit in terms of modeling. People don't always interact with everybody else in the rest of their country. That's an unrealistic assumption to make. And so each vertex represents a homogeneous community where the typical SEIR-type model operates. The edges between the vertices represent migration of individuals, movement. It's bidirectional. And the network does not change over time in terms of the number of connections and the number of vertices. That's static. Some models allow the population, the network to evolve over time, and we're not doing that. The aggregate behavior of the model represents the aggregate epidemiology of the whole country. And so that's what we really should focus on, and not the detailed results within each community, although those are interesting in their own right. Okay, so we have lots of different kinds of models. I wanted to start out modeling very simple ones, a very well-defined structure, to see if the structure of the networks has an effect. And these are very simple ones, simple linear ones, cyclic ones, various types of planar layouts on a grid, a rectangular grid, a trigonal grid, a hexagonal grid, or just a random planar network here. You can see that the degree, vertex degree histograms of these vary. The cyclic one, all the nodes are the same, okay? And here we've got mostly degree 4 nodes. We've got some degree 3 and a few degree 2 and so on. We can take these sorts of graphs and make them more homogeneous by doing them essentially on a torus, and then all the vertices are the same. They always have a connectivity of 4 or a connectivity of 6. If we do them randomly on a sphere, they generally have a connectivity of 6, but some have 5 and some have 7. We can also do what are called real-world networks using the Barabasi-Albert method or the Watt-Strogatz method. The Barabasi-Albert one tends to have a few nodes with very high connectivity. These are what we call hubs. Most of the nodes have very small connectivity and are connected to the hubs. And here, for example, here is a hub node, and we've got some hub nodes in there. The Watt-Strogatz model is more like a small world model, and the degree distribution is more even. Most of the nodes have about the same number of connections, and we don't have any hubs with very high connectivity. Which one is right depends on the situation. It's a very subjective choice. So we can take a very simple SEIR model and spread that out over this network. We'll do a very simple network of just 4 nodes, linear, so we can see what happens. The infection will start in the first node and then spread to the others. There's a function in the notebook here called distribute model that lets us distribute the SEIR model over our network, and we're going to use M as the migration rate constant, and we'll just gloss over some of those details there. We'll pull the variables, the force of infection, differential equations, and the expression for beta out of that and define our parameters. These are all the parameters, and we'll set the initial conditions. Everybody starts out healthy in each of the compartments, so all the S's are non-zero, and S1 has been reduced by some number of infected people. And then we can model that. And then here's our network. This is the simple SEIR model, and this is the SEIR model on a network. Here are the transitions, just 2 here, a lot of them here, including all the migration between the compartments. We can make the model graph, and this is generated automatically from the model description. The differential equations, again, things you can see get very complicated very fast. We can simulate it. This is the simple type of simple SEIR model that everybody has seen a lot in the past. And when we do it over a network, we start out everybody in the compartments, and then first the S1 starts to decrease because they're getting infected first, and then the infection passes to the second set of compartments, and then the third, and then finally the fourth. And we can look at the aggregate behavior here, which is just adding everything up by the health state. And we can see it is qualitatively different from the simple SEIR model, that the number of infected people is spread out over time, and it's not necessarily a symmetrical infection here. In fact, this looks like it's got a long tail, and here it has a longer rise, it looks like. We can also see that instead of everybody getting infected here, that some people don't get infected, and because of the network structure. So clearly there are some qualitative effects of the network on the results, and this is what we want to see, how important are they? So then doing this on the network for Italy, again, this is the network we're going to spread, or the model we're going to spread out over the network. We'll use 100 nodes just arbitrarily, and we'll generate the Watt-Strogatz and the Barabasi-Elbert networks. And these are the two networks we're going to use. We can see we've got one community here that's connected to 31 others and another one here that's connected to 23. And these can have some very, very big effects on the results. This takes a while to run, so I preloaded it, pre-computed it here. We'll pull out all of the data we need. We can see that we've got 1,100 variables in the model. We'll define our parameters. Everything's okay there in terms of being everything numeric. And then define the initial conditions. We'll run the model. And if we look at the model in detail, these are what the curves look like for all the individual 100 communities in the network, quite varied. The Watt-Strogatz one, or excuse me, the Barabasi-Elbert one looks very different. But if we aggregate it and plot that, then we see we get this curve here. We've got, you know, the asymptomatic or the severely infected that recovered, the mild and the asymptomatic. We've got three curves for the infected and quarantined here, one for the exposed and one for the dead. The susceptible I'm not showing because it's way off scale. And surprisingly, the plots for the Barabasi-Elbert model come out looking very similar to this. We can then look at the results here, and we see that with the Watt-Strogatz model, we have shifted it a little bit. It's a little bit lower, and it fits our data a little bit better. I didn't actually fit these. This is just the result of distributing the model over a network. The Barabasi-Elbert network, though, is very much the same as the original non-network model. The dash curves are right on top of the solid curves here. So it didn't change it that much. And that basically brings me to the end. So the artificial population sizes led to an unrealistic optimized set of parameter values, and that's what I was trying to overcome. Non-pharmaceutical interventions can play a crucial role in the model in terms of its behavior, and the real trick is trying to mathematically model what's happening socially within the population. Don't get caught up in the details of trying to model what the effect of masks are, what the effect of distancing is. It's probably better just to come up with an effective model that you can put a few dials on to control its shape. It's important to have asymptomatic in the model as well as different levels of severity. Quarantine, I think, is important because once people are hospitalized, they're not out circulating. And the asymptomatic is very important. We do have a death due to disease compartment, and as I said, non-pharmaceutical interventions are very important, especially for this disease here, trying to understand what's happening now while it's live, while it's happening. And we have demonstrated we can extend the model over a network, but a lot more work needs to be done in order to understand what the effects of the network are. And these are the resources, my packages, compartmental modeling and epidemiology modeling that uses the first one are published on the cloud. You should be able to access them. And I've got two Wolfram community posts, and these are some web resources that we're using to get the data. And I would like to thank you for your attention. And we are done exactly on time. So I will take questions at this point. It looks like we've got a few here already in the chat. Okay. Yes, Anton, you've been doing similar work. Shall I say great minds think alike? Probably not. Great minds often have very different ideas. And so your stuff here is posted, the links so the other people can see it. Yeah, you took a very systems type approach, I recall, from your earlier work related to modeling it in terms of stocks and resources and supplies and things like that. And you also included things like availability of hospital beds in the model and trying to come up with a model that policymakers could use, which I think is definitely what we need. I'm more focused on the biology because that's my interest. Nicholas. Yes, Germany and Sweden, very different outcomes. Jan Brugard is speaking about the situation in Sweden, and his talk is happening right now, I believe. So that might be good to hop over to that if you're interested in that. And yes, I really do want to model more countries to see how things are happening there and what we can learn from the behavior of the models in terms of disease characteristics and population characteristics as well. Thank you, Jorge, for the compliment. Let's see, the graph reflect the town connectivity. Do you mean the connectivity of people within the town itself or the connectivity of one town to another town? You should be able to unmute yourself. Or maybe Andy could do that.
Who's asking the question?
I was asking Jorgi a reply to his question about asking if the graph shouldn't reflect the town connectivity, and I wasn't sure what he meant by town connectivity.
Okay, I'm going to, he's set to speak now, so if you'd like to talk, he can jump in.
Hi, yeah, thank you. Yeah, I was wondering, I was referring to say since there's no flights, people move around basically by roads. So the geographical connectivity of this, essentially the road network.
Yes, yes, that's very true, and one could use a graph of the road network as your network to distribute the model. And in fact, you could even make it a bit more sophisticated by letting some roads have high traffic and other roads have low traffic as well. In the United States, it would be interstates connecting things. In England, it would be the M thoroughfares as opposed to the other ones. And I guess in Italy, they designate those highways with the letter I think. But yes, that would be very important. That would be another way to construct the model.
But sorry, but in that case, doesn't a highway network resemble more? Why would it resemble a small world network? Isn't like a country like Italy mostly like very high connected nodes and a bunch of very little connected nodes?
Yes, that could very well be the case. I looked, I looked at both. I simulated both, and we did see different behavior, but it wasn't as different as I expected it to be, which was kind of surprising. The aggregate behavior, the detailed behavior of the individual nodes was very different between the two types of graphs, but the aggregate was not. And it could be because of the size that I used, or the general, there are some tunable parameters on the Barabasi-Albert one, and I just chose one reasonable value for it and got a graph that looked okay. But you're right, the total connectivity is very important. And there are cities, like Rome seems to be connected to everything else, and other small towns would only be connected to their immediate neighbors, and not able to reach in one hop, as it were, from Rome to Venice or Rome to Milan. But people do that kind of travel, and so that your network should take that into account. Okay. Seth's question. Okay, making the network responsive to the force of infection. Not quite sure what he means by making the network endogenous. I think we did, and that does affect the overall force of infection, the aggregate, but we're still able to model it the same simple way at the lower level. And then seeing what the emergent behavior of the whole network would be, rather than trying to model the emergent behavior, trying to build that into the simpler behavior at the nodes. I think that's what you're getting at there, but we can talk later afterwards. And that looks like it for the questions. And thank you for the compliments, everybody. It's fun work. I really like working with these models. The trouble is you can get too caught up with your model, and you think that it's reality. So you got to be careful about that. You always have to think, well, what could I be missing, or what did I put in that really shouldn't be there? So thank you.